This is a challenging question. Fortunately, we have several options in the market to treat our patients. And choosing wisely means knowing the different available devices and technologies and surgical possibilities, and also having perfect knowledge on the clinics, anatomics and hemodynamics patterns of the patients. And we can offer and we should offer minimally invasive procedures to our patients that deserve any kind of intervention. In this list, in my opinion, we should not consider the old-fashioned classic stripping, not anymore. We have currently a minimally invasive open approach and a local anesthesia, sometimes plus sedation, but the patient can return to work the day after the procedure, ambulatory basis, as we have more and more endovenous modalities that includes the radiofrequency, laser, MOCA, glue, ultrasound-guided foam sclerotherapy. The different guidelines, the latest published European Society for Vascular Surgery guidelines that were published at the European Journal of Vascular and Endovascular Surgery this year, and also the just released American guidelines, put this in equation, and we can offer to different anatomical and hemodynamical patterns different approaches. When we are talking about having reflex of the great saphenous vein or reflex at small saphenous vein or reflex of the anterior accessory saphenous vein, if we have to perform or not concomitant phlebectomy. So, trying to answer to your question, in my opinion, we should have expertise and skills in different modalities. We should offer different possibilities to different patients in our departments, and all these technologies, that's for sure, that will help us too much in this decision. That is absolutely mandatory. When talking about cost effectiveness, we have to consider the health outcomes and also the costs. In the health outcomes, the parameters to be considered should include, that's for sure, clinical recurrence, improving symptoms, improving quality of life, cosmetic satisfaction, and in the costs, not only the costs related with the procedure, but also the costs related with the reinterventions, so the follow-up, and the costs related with the number of days that the patients are not able to return to work. So, of course, it is crucial to assess cost effectiveness, and this can be different from country to country, because the reality of the cost of the devices and the reality of the different expertise of the physicians can be different. At the end, we have to do that. The reimbursement politics means what is the value for money. And we cannot forget that value for money is mandatory. Well, this is a challenging question. I would say that when we analyze the development of the different technologies, even recently, what is the current perspective? I would say this is an ongoing assessment. It must be. Because not only having more data related with the clinical effectiveness of the different devices, but also having, if possible, lowest prices for the different devices. Because at the end, the cheapest solution, it is not mandatory that it is always the most effective for the great majority of patients. And we have to combine the price and the effectiveness, and not only when we are treating the patients in our first approach, but do not forget the follow-up, and all these considerations should have in mind at least a follow-up of 5 years. And at the end, I would say that clinical recurrence, it is not the same as having, for example, a rate of recranalization. So what it is really important is to assess the clinical recurrence, the symptoms, what the patients feel, and the quality of life and the number of complications related with the progression of the disease.